Welcome back to Master Oral Pathology. Today, we're jumping straight into a high-yield board review on a really rare but absolutely highly testable mucocutaneous disorder. We're talking about chronic ulcerative stomatitis. So if you're a dental student grinding away for your board exams or a clinician just wanting to sharpen that diagnostic edge, you are in exactly the right place. Okay, let's dive right into this deep review. We've designed this specifically to help you dominate your boards and, honestly, to avoid getting tripped up in the clinic. Because chronic ulcerative stomatitis, or CUS for short, is one of those incredibly tricky conditions. It's a total clinical chameleon. I mean, it looks like other things, it acts like other things, but it absolutely refuses to play by the rules of conventional treatment. So our goal today is to give you the exact framework to recognize it instantly.
I want you to think about your clinical differentials for a second. Picture this. You have a patient sitting in your chair with intensely painful, disquamative oral lesions, and they are completely unresponsive to the high-potency topical corticosteroids you prescribed. What should jump to the top of your mind? It's a super frustrating scenario, right? Now, if your brain immediately goes to refractory lichen planus or maybe mucous membrane pemphigoid, hey, you're definitely on the right track. But you might just be missing the exact diagnosis we're focusing on today.
We have a very clear path to clinical mastery today. Here is the agenda. First, clinical presentation, then etiology and pathogenesis, followed by histopathology and immunopathology, differential diagnosis, and finally, treatment and prognosis.
Section 1. Clinical presentation. The who, what, and where.
Let's start with the classic patient profile you're going to encounter, whether that's in your dental chair or on an exam paper. Recognizing this specific demographic and presentation, that is honestly half the battle. The classic triad for CUS breaks down into 3 key pillars. First, the demographic. This disease overwhelmingly presents in older, white females. Second, the location. You're going to see these lesions specifically targeting the tongue, the buccal mucosa, and the gingiva. And third, the presentation itself. Severe, debilitating desquamation and ulceration. Clinically, this usually shows up as fiercely painful erosions or irregular ulcers bordered by these peripheral white striae. And it's exactly those white striations that constantly confuse clinicians into thinking they're looking at erosive lichen planus. So when you see a board question describing a 65-year-old female with peeling, painful gingiva and buccal ulcers mimicking lichen planus, CUS absolutely needs to be on your radar.
And let's quickly clarify what we mean by desquamation here. We aren't just talking about some mild, asymptomatic irritation or a subtle little white line. No, this is a severe, active tissue-shedding process. The outermost epithelial layer is literally peeling away, and it leaves behind this raw, incredibly vulnerable, and debilitatingly painful oral mucosa. These patients, they struggle to eat, brush their teeth, sometimes even to just speak comfortably. It dramatically impacts their daily quality of life, and that is exactly why getting a rapid, accurate diagnosis is absolutely crucial.
Section 2. Etiology and Pathogenesis, the underlying mechanics.
So let's take a look at the molecular level to understand exactly why this severe tissue destruction is happening in the first place. You need to highlight and memorize this highly specific, very testable molecular target, DNP63A. To really grasp this pathology, you got to know what DNP63A actually is. It's an isoform of the p63 protein, which, as you probably know, is a homologous of the famous p53 tumor suppressor gene. This specific protein plays a fundamental, critical role in the stratification and development of the basal epithelium. Now, in patients with CUS, the body's immune system just goes rogue. It produces autoantibodies, which you'll find both in the tissue and circulating in the blood, that directly target this exact nuclear protein. That specific autoimmune targeting is the defining molecular hallmark of the disease.
But here's where the science gets incredibly fascinating and honestly kind of frustrating. Association does not equal causation. Even though we consistently find these anti-DNP63A autoantibodies in CUS patients, the medical community still hasn't definitively proven that they are the primary direct cause of the ulceration. Think about it. Are these autoantibodies actively causing the epithelial damage, or are they just a byproduct of some other hidden immune trigger that's actually destroying the tissue? Right now, it remains a pretty big immunologic mystery.
Section 3. Histopathology and immunopathology, the microscopic evidence.
Because the clinical presentation is so easily confused with other desquamative diseases, we have to look closer at what happens when you actually biopsy this tissue. Here is your exact diagnostic biopsy pathway, and you definitely need to master this.
Step 1. You take a biopsy and run a standard H&E stain. But beware, the H&E stain for CUS is famously deceptive. Why? Well, on an H&E stain, CUS shows a classic band-like or lichenoid lymphocytic infiltrate right at the epithelial connective tissue interface. Under a standard light microscope, that makes it physically indistinguishable from lichen planus. Literally, if you stop at H&E, you're going to misdiagnose your patient. Which leads us to step 2. You must pivot to direct immunofluorescence, or DIF, to unmask the true diagnosis. And step 3 is where the magic happens, identifying those specific perinuclear IgG deposits.
Look, if there is literally one thing you memorize from this entire session today, let it be this highly testable fact. Under direct immunofluorescence, CUS will distinctly show perinuclear deposits of IgG. What does that actually look like? It shows up as a speckled, ring-like fluorescence completely surrounding the nuclei of the cells, and it's specifically located in the basal and parabasal layers of the epithelium. And just as importantly, you've got to know the negative markers. You'll see a complete absence of staining for other immunoglobulin types, and crucially, absolutely no staining for fibrinogen.
Section 4. The Differential Diagnosis. Separating the lookalikes.
Because CUS is such a clinical chameleon, we have to carefully strip away the conditions it's pretending to be. So let's build a quick mental reference guide. Without that diff confirmation we just talked about, CUS is basically clinically indistinguishable from severe lichen planus, mucous membrane pemphigoid, pemphigus vulgaris, linear IgA disease, or even intense hypersensitivity reactions. So how do we actually tell them apart microscopically? Well, lichen planus responds to steroids and shows shaggy fibrinogen at the basement membrane on diff. CUS does neither. Mucous membrane pemphigoid shows linear basement membrane staining. CUS is perinuclear. Pemphigus vulgaris gives you that intercellular, chicken wire staining and usually presents with massive systemic issues. CUS is perinuclear and completely localized. Linear IgA disease obviously shows linear deposits of IgA, not IgG. Understanding this exact microscopic profile is exactly what separates CUS from its mimics.
Section 5. Treatment and Prognosis. The Clinical Resolution.
Okay, let's get into the treatment phase, which is where nailing the definitive diagnosis of CUS dictates a major, life-changing pivot in your prescription pad. And this brings us to the ultimate diagnostic trap. Normally, when you see a fiery red, immune-mediated oral lesion, your first instinct as a clinician is to just throw high-potency topical or systemic corticosteroids at it. But with CUS, the response to steroids is notoriously poor. They are typically totally ineffective. However, once you make the correct diagnosis and pivot to the antimalarial and immunomodulatory drug hydroxychloroquine, the patient shows this fantastic, rapid clearance of the lesions. Hydroxychloroquine is absolutely the gold standard therapy here. But, and remember this highly testable board fact, before you start a patient on long-term hydroxychloroquine, you must mandate a baseline ophthalmic consult. Why? Because of the rare but super serious risk of macular toxicity, often called bullseye maculopathy. Knowing when to pivot to this drug is going to save your patient months of agonizing, totally ineffective steroid treatments.
So once you actually have the patient on the right treatment, what do you tell them about their future? Well, the great news is that CUS has an excellent long-term prognosis. It is entirely localized. It stays strictly confined to the mucocutaneous region. It is not going to evolve into some systemic autoimmune crisis. And unlike some other oral lesions, it isn't linked to GI tract disorders, like Crohn's or ulcerative colitis. And perhaps most importantly for your patient's peace of mind, there is absolutely zero reported risk of malignant transformation.
By remembering the specific demographic of older white females, the critical reliance on direct immunofluorescence to spot that perinuclear IgG marker, and the absolute necessity of pivoting away from steroids toward hydroxychloroquine, you are totally equipped to handle this curveball. Master the diagnosis, master the pathology. If you found this breakdown helpful, make sure you subscribe to Master Oral Pathology for more high-yield board reviews just like this one.
Before we wrap up, I want to leave you with a final thought to chew on. We know that DNP63A autoantibodies are heavily present in CUS, right? But if they don't definitively cause the desquamation and ulceration themselves, what exact immune trigger remains hidden in the background of this disease? What is the true spark of this fire? Until we unlock the exact molecular role of these proteins, you got to keep questioning the pathology, stay curious, and I will see you in the next deep dive session right here on Master Oral Pathology.